Bismillah ar-Rahman ar-Rahim. This is Dr. Muhammad Jawad from Nephrology Nursing Program at High Institute for Health Specialty. Our lesson today is sodium modeling. Many modern dialysis machines offer options for ultrafiltration and sodium profiling or sodium variation system. User interest in these options and the eventual response of industry was driven by an attempt to improve tolerance for ultrafiltration as dialysis sessions time became shorter and an associated increase in patients' tolerance for the consequent higher ultrafiltration rate was observed. The concept behind ultrafiltration profile is simple. Vary the ultrafiltration rate in such a way as to improve vascular refilling. The principles behind sodium variation system are more complex. One idea is that high dilute sodium at the beginning of the dialysis, when the solute removal rate is maximal, would deliver osmolar solute to plasma water and combat any tendency for movement of extracellular water into the intracellular space. The second is that diffusion of sodium from dialysate into plasma water would exert an osmotic effect, tending to increase plasma volume filling. Another basis for sodium variation system is that even a small consequent rise in plasma water sodium concentration exerts an effect to increase peripheral vascular resistance. In sodium variation system, the sodium content of the dialysis fluid is varied during the course of the treatment to directly influence plasma sodium levels. The aim is to slow the rate at which sodium leaves the bloodstream into the dialysate. There can be negative consequences to high dilute sodium concentration. Sodium can accumulate in the patients, leading to an increased post-dialysis thirst, increased intradialytic weight gain, and development of hypertension. Sodium variation system was developed to achieve the benefits of high plasma sodium level while at the same time avoiding unnecessary high intradialytic sodium uptake by the patient with the associated risk of sodium loading. Sodium variation system allows modification of the plasma osmolarity during the dialysis session to minimize intradialytic side effect while removing the amount of sodium necessary to avoid sodium overload. In isonatremic dialysis, the sodium concentration in the dialysate should be higher, approximately 2 to 3%, than in the plasma to avoid net diffusive loss and gain of sodium. When difference in concentration exceeds this, the plasma sodium concentration increases linearly with the increasing concentration gradient between the dialysate and the plasma, and at a rate which depends on the body weight and total body water. The minimum and maximum dilute sodium concentrations are generally limited for physiological and technical reasons. Example 130 to 155 millimole per liter in Fresenius Medical Care NA machines. It is recommended not to exceed 4 to 5 millimole per liter. Sodium variation system is only advantageous for the patients in the long term if it results in neutral sodium balance. Here in this picture you can see water flux contains sodium nearly isotonic to plasma water, and sodium removal from patients no concentration changes. In this picture you can see the balance neutral profile. The yellow line, this is the sodium profile, and the blue color, it is a plasma sodium without profile. Interdialytic water and sodium loads must be corrected on an individual basis because they vary from patients to patients and from one session to the next. Therefore, a post-dialysis plasma sodium concentrations target must be determined for each individual patient. To determine the optimal target, the clinical circumstances, absence of hypertension and fluid overload, the individual pre-dialysis sodium level, and overall sodium balance of patients must be taken into consideration. This is easiest for a stable normonatremic patient, as the sodium concentration post-dialysis should be generally be the same as the pre-dialysis. A normal sodium value post-dialysis can also be reached by sodium variation system for hyper or hyponatremic patient. However, monitoring of patient's clinical status will indicate if post-dialysis normonatremia is indicated. For example, hypernatremic patients often stabilize at the sodium level that is higher than the post-dialysis level and may suffer side effects. If hyponatremic dialysis is conducted with the intention of lowering their sodium levels, nevertheless, gradual normalization of plasma sodium levels is necessary in the patient's group if hypertension due to sodium and fluid overload exists. Hyponatremic patients often regain their lower plasma sodium concentrations during the interdialytic interval due to thirst and subsequent increased water intake. This occurs from hypernatremic dialysis sessions that are conducted with the intention of normalizing post-dialysis plasma concentration. This could be especially dangerous for patients in which hyponatremia is secondary to water overload and or is associated with the heart or liver failure. Types of sodium modeling profiles. There are a number of sodium modeling profiles that have been proposed for different clinical situations. Number 1, decreasing profiles. These profiles are the most widely used because you can take advantage of the positive effect of high dialysate sodium concentrations on plasma osmolality and plasma refilling at the beginning of the treatment. When ultrafiltration is best tolerated, sodium accumulation at the end of the treatment may be prevented by then lowering dialysate concentration. The effects of linear step and exponential profile forms have been examined in some studies. Post-dialysis hypotension and early intradialysis hypotension were best attenuated by decreasing stepped profile, while linear profile sometimes reduce muscle cramps and late intradialytic hypotension. However, these positive effects were not seen in other studies. Number 2, alternating profiles. These profiles were introduced in the early 80s with the aim of inducing an alternating fluid shift across the cellular membrane to improve the transport of uremic toxins out of the cell by solvent drug. The incidence of the disequilibrium syndrome was found to be reduced with the use of these profiles type. Number 3, increasing profiles. These profiles are less commonly used. They can preserve the plasma volume during the last period of dialysis in cases where the ultrafiltration is still high, and have been reported to be especially beneficial in reducing the incidence of muscle cramps, probably because of reduced sodium removal. Thus, caution should be exercised when using this profile. Increasing and alternating profiles are not provided by Fresenius Medical Care NA machines. Recently, some studies evaluated the effect of sodium balanced neutral sodium profiling, ultrafiltration profiling, and their combination on preservation of blood volume, cardiac function, and occurrence of hypotensive episodes during using a Fresenius 4008S machines. They observed that similar intradialytic sodium removal with the use of sodium balanced neutral linearly decreasing sodium profile combined with the linearly decreasing ultrafiltration profile, greater intradialytic stability of blood volume, blood pressure, and cardiac functions could be obtained, and hypotensive episodes were significantly reduced. Accurate sodium variation system requires the ability to predict the final plasma sodium concentrations that would be achieved by each profile type and technique to accurately follow the changes in plasma sodium levels during the session. Mathematical models are available for the prediction of post-dialysis plasma sodium levels that result from the profiles. In summary, ultrafiltration is the optimal choice to maintain cardiovascular stability during fluid removal, as the ultrafiltration rate can be varied to improve vascular refilling. Although there are many controversies surrounding it, sodium variation system may support fluid removal when used appropriately in carefully selected patients or in combinations with the ultrafiltration profile. Sodium variation system should always be balanced neutral and may not be necessarily with longer or more frequent treatment. These are the references that if you need to read more about this concept. Thank you for your attention, and I am looking for your questions and feedback. I hope to meet in the next online lesson. Thank you so much.